Welcome everyone to another Road to Wellness webinar. My name is Kathy Olewski and I'm the host for tonight's webinar. I'm also a patient living with MPA vasculitis. I was in treatment for 6 years and I've been in remission off treatment for 7 years. Today we're doing another one of our vasculitis disease specific webinars. This one is on CNS vasculitis. I'd like to begin by telling you a little bit about our two guest panelists today. First, we have Dr. Roula Haj Ali, is a professor of medicine and staff physician at the Center for Vasculitis Care and Research at Department of Rheumatic and Immunologic Disease and associate director of the Vasculitis Center at the Cleveland Clinic. She's board certified in internal medicine and rheumatology. We also have Chris Kelbrantz, a vasculitis survivor of 20 years and author of a book about her own journey, The Maze of Thorns. Chris is a graduate of the University of St. Thomas and currently works in healthcare and spends her free time writing a natural wellness blog and practicing yoga. And she lives in Apple Valley, Minnesota. Well, welcome to both of you. We're excited to have you here tonight.
Thank you. We are very excited and thank you for hosting us.
And I think at this point, we're going to ask Dr. Haj Ali to just give us a little information about CNS, and then she's going to talk with Chris a little bit about her journey. So if you'd like to go ahead and take it over, Dr. Haj Ali.
Sure. All right. Well, thank you, Kathy, for having us. It's a great pleasure to be with you today, especially that Chris with us here. And what I'm going to do first is to give a little bit overview of what is CNS vasculitis. What do we know about it? And there's a few considerations here that I put together. First, CNS vasculitis can be primary or secondary. Primary meaning just confined to the brain or the spinal cord. There is no vasculitis anywhere else in your body. And there are different terminology you can find in the literature, something called PACNS, which is referred to as primary angiitis of the central nervous system. So CNS is central nervous system, or CNS vasculitis, or granulomatous CNS vasculitis. These are all terms that you can find that represent primary or just brain vasculitis without any inflammation anywhere else. But CNS vasculitis can also be a manifestation of other systemic disease, such as other vasculitides, such as GPA or MPA or polyarteritis nodosa or EGPA, or even other systemic diseases such as mixed connective tissue diseases or sarcoidosis, or it can happen secondary to infection. So diagnosis of CNS vasculitis is challenging, and that's because of different reasons. The ultimate best tool that we have for diagnosis is the brain biopsy, and this is not accessible all the time. And sometimes it's hard to really get a biopsy from the brain, or it's too dangerous to get it from the brain. And we used to know that this is a uniform, just one form of a disease, but the more we know about it, we know that this is heterogeneous and it's present in different way. And also when we look at pathology and the way it comes in different patients is different, which pose different challenges as well in understanding this disease. And sometimes we clinicians have to start treatment even though we're not certain 100% about the diagnosis. And that's posed a big challenge as well. Because of the rarity of the disease, there hasn't been what we call a controlled prospective trial or large trial to better understand what medication works better in this condition. And the lack of very specific diagnosis diagnostic modality also pose a big challenge in this condition. We don't have a specific test, whether it's a blood test or whether it is an angiogram or an MRI or MRA, which I'm going to talk more about it, that tell us that this for sure the diagnosis of CNS vasculitis. So there is a lot of challenges in this condition, and that's why patients, when we're going to learn from Chris' journey, that patient, takes a long time for them to be diagnosed and recognized. But however, hopefully over the years, we have done a little bit better with that. So this is a slide that tells us that CNS vasculitis can occur sometimes in the brain or the spinal cord by itself. And this is what we call as primary CNS vasculitis. And to give you a little bit background, there's a lot of vasculitides that occur in one organ. We call them single organ vasculitis. So sometimes patients come in for a gallbladder surgery and the pathology comes out as a vasculitis, and it's only in the gallbladder, which we call this condition isolated single organ vasculitis. And this is what is primary CNS vasculitis. There have been criteria for the diagnosis of CNS vasculitis, and these were proposed by mentor Len Calabrese. And what he proposes that patient to be diagnosed with CNS vasculitis, they have to have either an angiogram, which is a catheter that's placed in the arteries, and they look at the pictures of the arteries, and I will show you some picture. This is an angiogram, and they look to see if there is any narrowing of these vessels, or you can biopsy patients from the brain and demonstrate there is a vasculitis. So either or of these can make a diagnosis of CNS vasculitis. However, the most important, you have to exclude all conditions that can actually cause these findings. So these findings of either finding of biopsy of vasculitis on the biopsy or an abnormal angiogram, they're not very specific for CNS vasculitis, and they can occur in other conditions. And it is a very important task is to actually exclude what we call the mimics, and there are many of them. You can have CNS vasculitis in systemic inflammatory diseases, as we talked about. You can have abnormal angiograms in patients who have other forms that can cause strokes, such as what we call emboli, where patients have clotting and the clots comes out from the heart or somewhere else, and then block the artery, and all what you see is a blockage of the artery. Or you can have infection in the heart, and then you start showering some bacteria, and the bacteria goes into the artery and block the artery. So, and then infection themselves can actually cause inflammation in the arteries, and they can look like any blocked arteries on an angiogram, or it is inflammation on the biopsy itself. And there are other miscellaneous diseases, whether genetic or autoimmune encephalitis, or either lymphoma and cancer. They can look sometimes as CNS vasculitis on the biopsy. So really, it's a big task and challenging task, and you have to include a big group of a team from a different discipline and subspecialties to really help you in making the ultimate diagnosis. And that takes a long time, and you have to be in the right place where you have these resources, where everybody can look at the patient from their own perspective. So I put in this slide that shows an example of an angiogram. And I said an angiogram is a catheter-based study where they put dye inside the arteries, and then they take picture of the brain vessels. And this is pictures of a brain vessels. And where you see, narrowing here, this is another narrowing, and also here and here. and as well here. And when you see narrowing, this could be because the vessel walls themselves are inflamed, and that has caused narrowing, or could be from other different reasons, as we talked about. So that could be consistent with CNS vasculitis, but however, also could be secondary to other entities, and this is where the challenge occur. This is a biopsy with a patient who have CNS vasculitis. This is the artery, and this is the layer of the artery. So the artery in the brain, this is brain tissue. The artery shouldn't have so much layers of inflammation, and you could see how much layer of inflammation. If you actually look here, this is whole inflammation. This is a nodule, a granuloma inside the vessel wall, and it's a lot of inflammation here. And as the inflammation, becomes more and more, your lumen here, which is the opening that the blood goes through, becomes narrow and narrow, and then no blood flow comes through. And after that, the blood vessel just become clogged, and the blood flow doesn't go through, and then there will be ischemia, which is no blood flow in the tissue, and that can cause strokes and other neurologic deficits. So these are the two ways we can diagnose patients with CNS vasculitis usually. But you have to put into that multiple different factors. So when I see a patient with CNS vasculitis, what I see is that patients could have...
Call from 8012 4997.
So diagnosis of CNS vasculitis could be very challenging, and we have to put together not only the biopsy and angiogram, but also there are multiple factors that we put together. And when I see a patient with CNS vasculitis, I have to look at their history, their physical exam, their blood test, and other specific tests that I would like to talk about. So if you look at the features and the clinical feature and the symptoms with what patient present with CNS vasculitis, could be very much anything from headache to change in mental status, to stroke-like symptoms like inability to move an arm or a leg, or slurred speech, or vision changes, dizziness, nausea, vomiting. So it's a lot of complex of features that can happen together. But most commonly, what we have seen is that patients present with headaches for some time. And then later on, something else happens, such as stroke-like symptoms. This is the most common presentations. And when we evaluate our patient, we ask them about different symptoms to try to find out if there is any systemic diseases. We try to find out if there is vasculitis in somewhere else in their body. So we ask about fever, weight loss, rashes, sinus problems that could explain things or point to things such as GPA or sarcoidosis. We ask about hearing loss, inflammation in the eyes, sores in the mouth or the private area that could happen with Behçet syndrome, or anything such as neuropathy or discoloration in their hands or feet, kidney issues, blood clots in the past, infections, have they traveled somewhere else? Has there any family history of any unexplained neurologic disease that could point to a genetic disorder? So this is all put together to really assess if there is any other reason that the patient having the symptoms, and it helps us to rule out other things before we really make the diagnosis. But one important diagnostic workup is the spinal tap, so which is, we call it the lumbar puncture, and this is a procedure where the doctors will go in between the vertebra and then take a small sample of the spinal fluid, which is around the spinal cord, which is the same fluid which is around our brain. So that spinal fluid will tell us if there is inflammation in the brain. And it's really important to have this fluid results, and we should not omit this procedure unless there are risks of doing it. So it is very important diagnostic workup in our journey. And what we do is that if you have signs of inflammation, it could be from just inflammation, or it could be from infection. So you have to make sure that the patient doesn't have infections. And most of the time, patients we have CNS vasculitis have inflammation in their CSF. So it's a very good, first tool to really have in hands. And then, after, blood tests are really very important to rule out other conditions. But in primary CNS vasculitis, where the inflammation is just in the brain or the spinal cord, all the blood tests that you could do are normal. There is no inflammation in the blood. The SED rate and the CRP are normal. The ANCA is negative in primary CNS vasculitis, and all other serologic tests are negative. But you do these tests and you do other testing for infection, etc., to really rule out other diseases, in addition to other things depending on the history that you take from the patient. And ultimately, if you don't have answers, we really get a brain biopsy. And, I put there that it is underutilized, and it is a valuable tool in the diagnosis, but it is imperfect. And the reason I said imperfect is that because in about 75% of the time we have answers, but unfortunately in 25%, the biopsy can still be negative, but the patient can still have CNS vasculitis, and that we make a diagnosis based on ruling out other conditions, and we're putting everything together. So when we explain to our patient the diagnostic procedures that we usually do, it's really very hard to tell them, we're going to go in and get a brain biopsy, but unfortunately, this is not going to give us 100% diagnostic certainty. However, it is important because we know in about 40 to 60% of the cases, even though we don't find CNS vasculitis, we may find other diseases. So it is imperfect, but it can help us in ruling out diseases as well. So I'm going to talk a little bit about some of the advances that we have encountered recently in our journey with CNS vasculitis. And one of them is called next generation sequences on the CSF. So when you take the CSF, the fluid around the spinal cord, you can take it and then run next generation sequence for infectious workup. So this is really a very good test, even though you're not testing specifically for each infection, you are testing if there is any infection, even though you don't know what is the infection. This is a new test that we have been doing. We actually send it out to UCSF. We started this test as a research test with them, and they are leading this effort. And the turnout test is still a little bit long, but it is a very important test in our workup of patients with CNS vasculitis, because it gives you unbiased way to look for infection. Another important advances in our CNS vasculitis is imaging of the vessel wall. And what I mean by that is that, when we look at the vessels, we look at two different things. We look at the lumen, where if there is blood flow, and this is what the angiogram, and I show you a picture of the angiogram where there are narrowing in the lumen itself. But the angiogram is not going to give you information about the wall of the vessel. But this test will give you information about the actual wall of the vessel. And this is a specific technique of the MRA, which is magnetic resonance angiogram, which is like an MRI, but of the vessels, and with a special technique, we can look at the vessel wall itself. And let me show you some pictures here. This is a vessel which is narrowed here, and it's a little bit narrowed here, more so here. But look at the vessel wall. This is the wall of the vessel, and you see a little bit of white area here, which we call enhancement. But you see it more here on both sides. And this is a patient with CNS vasculitis, and this vessel is inflamed, and this is why the vessel, when we put dye in the vein, the vessel wall took the dye because of the inflammation. And this is after treatment, the vessel wall has actually, the inflammation has reversed. This is a perfect situation, but unfortunately, it's not always perfect this way. And sometimes you can see some uptake and enhancement in patients who don't have inflammation, but atherosclerotic disease, which is hardening of the blood vessel. But from the pattern of the enhancement, you can tell which one is. But this has to be interpreted by a very good, a neuroradiologist who actually has experience with that. And there are effort in standardizing these techniques, and we have been doing some research on this as well. So these are two important advances that we have been using in our diagnosis of CNS vasculitis. And I'll give you an example of how we can use it in practice. This is a patient with vasculitis here, where you see the inflammation around the blood vessel. This is a patient with RCVS, which you don't see inflammation of the blood vessel. And RCVS is an entity called reversible cerebral vasoconstriction syndrome, where patients present, they're young, present with stroke, and they can also have hemorrhage in the brain. And the angiogram, look at the angiogram, looks exactly like a vasculitis, but it's not vasculitis. This is not inflammation. This is a vasospasm in the brain that mimics CNS vasculitis a lot, and people mistaken it as CNS vasculitis. The CSF in this condition does not show inflammation at all. And patients present differently with very bad headache, what we call it thunderclap headache, different than patients with CNS vasculitis, where their headache is a little bit more, like a gradual. Okay, so what do we think that causes CNS vasculitis? This is a $1 million question, but we have some speculation here. We think probably infection may have set the stage for vasculitis, or there is a change in the virus, or there's some mutation that we acquired over time that made us susceptible to have vasculitis, or there are multiple different things. Genetically, something happened with us, or environmentally, something triggered us to be susceptible for getting inflammation in the brain. So it's not really clear why we have it. I wish we would have more answers, but hopefully when we put our efforts together, we can have a little bit more answers on this. But what happened when CNS vasculitis occur? So these are the blood vessels. They start from the vessels this is the aorta down here, and then it branches out with the carotid artery, and then vertebral arteries, and then as they go inside the brain, they become smaller and smaller, and they branch out. And you can see how they branch out here. And when you have occlusion or narrowing of the vessel, you can have, the vessels that supply that area, it can be affected, and it will not have any blood supply, and it will lose the function of that area, and it causes the symptoms. And the purpose of the treatment is to reduce inflammation of the vessel wall, so that we can decrease the damage of the affected cerebral blood flow, and then hopefully to maintain a blood flow. But unfortunately, depending on what stage you treat the patient, not the vessel wall may not go back totally to normal, and you may have some fixed narrowing all along, but you have to stop the progression of the disease. How do we treat patients with CNS vasculitis? We treat them, after your diagnostic workup, you treat them with what we call induction therapy and maintenance therapy. So you have high dose of glucocorticoid. Most of the time we use a IV high doses of steroid, and then thereafter, we add to that either medications such as cyclophosphamide or mycophenolate, mofetil, and then that goes for about 3 to 6 months, and then later on, as the prednisone and the steroids goes down, you have to maintain our patients on some maintenance therapy to keep things into check and in remission, because we know that their relapses occur in this condition. And if you ask me for how long we keep our patient on maintenance therapy, which is a very good question, it all depends on whether the patient has multiple relapses. I would not take them off medication, whether they have problems with the medications or not. There has been some series that looked at relapses and the risk of relapses, and unfortunately, if you compare series to series, they were not the same conclusion. But what we know that male gender has a higher risk of relapse. Some patients who have more inflammation on the brain by MRI, they have more relapses, or patients who have seizures may have more relapses, and patients who relapse have a higher risk of relapses. So over the years, we have actually gone much better in our understanding of CNS vasculitis, where originally was reported post-mortem. But over the years, when cyclophosphamide was started in these patients, we have seen a much better outlook for these patients, and we started to know more and more about them and define them when Dr. Calabrese and Malik put their criteria together. And then Dr. Lee has put in a very nice review about the pathology of brain tissue and how we look at that. And then we have pulled out, some of the mimics, which we, the big one, which is RCVS, and define it very well, so people and physicians know exactly this is not CNS vasculitis. And Dr. Bensler and her team has done a great job in understanding better childhood CNS vasculitis, and we have multiple diagnostic advances. So what do we go from here, and what we are doing? All what we've done is great, but it's not enough. And the only way to advance this is by putting our efforts together. And we have a great initiative through the VCRC. We are leading this in the Cleveland Clinic with the help with the VCRC and Dr. Peter Merkel in putting together all big institutions to have a bioregistry of our patients to better understand this. We're going to have a bioregistry through the VCRC that include patients, all the clinical features as well as biologic samples. And that will be available for us in a very systemic way to better understand this entity as a group together. This is a rare disease, and we cannot do any research except if we put our hands together. And hopefully you will hear soon about this initiative. And the Vasculitis Foundation has been doing a great job in disseminating these studies to all our patients. I'm going to stop here, and we will have a discussion with Chris, and we will also answer some questions as well.
Okay, well, thank you so much, Dr. Haja Ali. I think that first of all, as a MPA vasculitis patient, I don't know enough about the other vasculitides, and I'm very excited to be learning this kind of information. I've just touched on it a little bit. And I think what would be great right now is if we let you and Chris talk a little bit about her journey, and you can ask some questions that'll be helpful to all of us about that.